My name is Arthur. I'm from Porto Alegre, Brazil,
Ah, wonderful.
and and today we're going to interview Dr. Joseph Broderick, the professor of neurology from UC Gardner Neuroscience Institute. So, Dr. Broderick, can you please give us a summary about your background and current area of research?
So I've been in stroke research since I came back from the Mayo Clinic to be back as a faculty member at University of Cincinnati, 1987. I was very active in the original pilot TPA trials when we did those at Cincinnati, and then in the pivotal trials, and been involved with a bunch of stuff along the years. Started a very large epidemiology project that still goes on here at UC for our region, and it's used a lot of the statistics out that come from the country. Started a project related to hemorrhage, done work in genetics of hemorrhage with the global study called FIA, and then really have through all of this been involved with acute stroke. So both on the ischemic side with the IMS trials and the TPA trials and other trials as well that are going on now called MOST, and then with intracerebral hemorrhage, which right now we're just starting the fastest trial, which is another global trial.
Great. So, Dr. Broderick, this channel was created for stroke fellows and young neurologists who are
Yes.
in the beginning of, in the beginning of their careers and want to learn from the experience of the great names in their field. So, I know that we could spend hours talking about hematoma expansion and exciting new drug treatments for ICH, uh, but I'd like to get away from that technical talk because I know that besides being an attending physician and a researcher, you're also an educator, and that interests me. So I would like to take this unique opportunity to get your personal perspective on that aspect, if that's okay.
Yeah. So one of the things that's very enjoyable for me in my career is being a mentor to younger. At one point, I was young coming in, but to be younger investigators, and so many of the projects that I've been involved with or started, I usually had young investigators that would join me, and then I would hand basically the project over to them as they became acquainted with it and manage it, and so it's a way of launching careers. And that's been great to see, some very talented young people do great things on their own. But it's one way to get them started. I think getting people involved in actually in a project that you're involved with. And then I've also in our country there's what's called training grants, which are funded by the government. And I've been primary mentor on a number of young investigators who've had project on their own, and my role is to try to help them think through things and plan for the future and get their project done, and which is then a launching point for another bigger project, independent projects. So I've done a lot of that work, and it's fun just talking. I've been involved with a lot of the fellow training programs in the North America, but also been involved with the WSO, and it's great to see everybody has different situation that they're in, and everybody is starting from a different place. So you have to listen to where people are, and you have to come up with what they can do in their own environment. So it's going to be very hard if you're in the middle of a country where there's no thrombectomy capable centers to do a thrombectomy capable study unless you move out of the country. So you have to kind of say, what are the issues that I can address where I am, and how can I do that in the scientifically most valid way possible. So that's, I think, what you want to do as a mentor to help younger people who are embarking on their careers.
Sure. Here in Brazil, we are still a developing country and we can encounter some shortages, uh, basically on treatment and new technologies. So In the last 20 to 30 years, we've had major advances in diagnosis and treatment in neurologic diseases, especially in the vascular neurology set. That was mostly driven by evidence-based medicine and clinical research. So, having participated in that history, what do you think are the biggest gaps that we still have and to answer, and how close are we in achieving them?
So it's sort of like predicting the future. So that's the question I've been asked before. I think uh, that in the area of acute intervention for ischemic stroke, that we're getting closer to the where cardiology has been for 10, 15 years, where you're going up against the biological limits of reperfusion. So how quickly you can do it with the devices and the medications. And I'd give that probably another 10, 15 years before we kind of have mapped out as much as we can um, the major ways to make people better who have acute ischemic stroke in the first 24 hours, and sometimes it'll be after that. And that's using imaging and devices and medications and even devices in the field to kind of identify people who have who are candidates for treatment. So I give that another, as I said, 15 years or so, and I think then we're going to be stuck where cardiology is, where the differences that you're going to find are so small, you're going to need huge studies to find the small differences. And really, it's not been any major, I would say, advance in acute MI treatment for the last 10 years because they do a pretty good job with it right now. So that's, but I think we have more room still in stroke. And when you're talking about developed and developing countries, that I think you can add another 10, 15, 20 years onto a developing country in terms of translating where the countries have treatments that initially are very expensive. And then as time goes on, they become hopefully less expensive and more available in the other countries. So that's kind of, I think, the situation with acute. With prevention, I still think we're trying to identify, we're still trying to identify the subgroups of patients who benefit from specific therapy. So, for example, we have all the embolic stroke of uncertain source, and we're trying to see whether we could do better than aspirin or antiplatelets. And I think we're making progress there. I think we'll find some other subgroups that are better treated with anticoagulation or other treatments. We just had the ticagrelor, presentation here just from China. Again, one of those other kind of advances in terms of how we use genetic information to maybe at least in some populations, to target therapy. So I think we'll have more targeted prevention therapy. I think the area of stroke neurology that has the largest and longest future is recovery, and that's something you can do, I think, in developing countries. Maybe there's different unique ways of doing recovery that you could use with an iPad, or you can do with more intensive therapies. I think that's an area that there's ability to translate it into the developing countries more than some of the acute therapies where there's a need for certain type of technology. So that would be, I think that's what has the longest time window of, to next century, because we're still learning how the brain works. And the more you know how the brain works and cells talk to one another, and we can probably come up with better ways to help the brain function, or at least give accessory technology that helps the person function. So, but anyway, those are my thoughts.
Perfect, thank you. So, can you tell us a little bit about your experience coordinating StrokeNet? Like, in your experience, what what a successful trial made of?
Yeah, so we take one of the things we do in StrokeNet is we take ideas from with the people within StrokeNet, and it's big. We have 26 regional centers and over 300 hospital sites participating in the trials themselves, and we actually have more that are actually could. But what we do is we try to help with working groups in acute and prevention and recovery to encourage ideas and concepts. And then those concepts are fleshed out. And then in the working groups, we have some very smart people from around the country work with those people to come up, make sure the concept is good, feasible, and then it goes to the government and they say, yeah, this is something what we want to see more of, and then it gets worked on, fine-tuned, and then we submit it for funding. And then it may or may not get funded, but about 35% of the projects that have been submitted have gotten funded at this point, which is a high ratio. But you need a good idea. You need people that are experienced about how to do trials. So generally, when you're a young person, you may have a great idea, but you may not have the practical experience of how trials need to get done. And so having somebody with experience as a co-principal investigator is very helpful. And then you need the tools to get the study, and then you need the sites. You need good sites that can recruit. And unfortunately, COVID has made things really hard for recruitment over the last couple of years. So, that's been one of our challenges within StrokeNet and across the world, quite frankly. So, hopefully, as we come out of that, we're going to start recruiting at a higher rate than we have over the last year or two.
Okay. So after we gathered all this knowledge from clinical trials, and what do you think is the key to disseminate this knowledge throughout population, and how can we communicate and apply those recent findings to our patients?
Well, I think it's multifactorial. So, first of all, you have to convince the other physicians in the community that this is something they ought to adopt. Because without physician buy-in or practitioner buy-in, it's really hard to sell it to the community, right? I mean, that's what happened with TPA originally back in the US back in the 1990s, is that the emergency physicians didn't feel comfortable, the neurologists didn't want to change their lifestyle. And so if you can't get the physicians doing it, it's hard to make it move into practice very quickly. You also want to make sure that whatever costs they're going to be there in the new therapy are covered in some way so people can afford them. And that's been a problem in developing countries, where I remember in Asia when TPA was there and there's no insurance, for example, people would pay for as much TPA as they could afford, or a lytic area. And that's something that you need the governments behind that as well to kind of support these treatments. So you have to convince physicians, you have to convince the government that they should fund things, and then you talk to the community about what it is that is there, and that can be done through social media, that's through the news, through a lot of different mechanisms. But you have to be relentless and keep doing it, because you have it takes a while to make change. It takes a while to take something from the research trial to where it's consistently delivered across a country, and it's even harder when you're in a developing country. So
Sure. Thank you. So my last question for you today is like, can you tell us a little bit about the everyday life of someone who is successful and actually got there, and what are the skills that we need to get there?
well, first of all, you got to enjoy what you like, enjoy what you do. So if you really like your job and what you do, that makes work great. I'm actually on stroke call today, so acute stroke call. We've already valued about 8 or 9 patients by telemedicine today, across our region, and I got somebody to cover for me for a half an hour. So, and while we are talking, I think there's been like 3 or 4 more calls. So, you have to, you have to like what you do, and I like the acute intervention of making decisions, looking at data, and helping other physicians, make decisions in the emergency department or in the hospital. So you have to like that. It's good to have, if you're going to go into research, you have to like to be able to do multiple different things. You still got to keep your clinical skills up, but you do have to put time in to learn about research and understand it. And you have to be comfortable with kind of moving from one thing to another. So I'm going from acute stroke call to talking and, on a World Stroke Conference to fellows, and then I'll go back in about 5 minutes here and do that again. So you have to be comfortable with moving back and forth in different roles, and you have to like what you do, and you have to keep learning. I've been doing this for a long time, and I learn something new every single day, whether it's in the literature, whether it's the patient I see, whether it's from my colleagues. So just keep an open mind. There's so many smart people in the world, and there's so much opportunity. Take advantage of it all. Don't close your mind. Don't close your mind. Keep your mind open as you get older.
All right. Thank you, Dr. Broderick. I think that concludes my questions for today. I really appreciate you taking the time to talk with us. So
You're
thank you.
very welcome, and all the best to you in your careers. Hope we get to meet in person sometime.
Sure. Thank you. Bye-bye.
Take care. Bye.